Hi, good morning, everyone. I'm really honored and privileged to be speaking here today, and thank you to the conference organizers to having this conference in this beautiful corner of the world. I'm really happy to be back in the Northern Hemisphere. I'm originally from Mongolia, and the smoking ceremony was right up my alley. We do the exact same thing in Mongolia as well. The smell was exactly the same. I wanted to ask Councillor Roth for the plant that he was using. Now I live and work in Australia on the land taken care of by the Kombumerri people of Yugambeh language groups. In Australia, we acknowledge our traditional custodian of the lands on which we live and work, and I pay my respect to the elders past, present, and emerging. And I would like to do the same to the Canadian Indigenous people who've taken care of this land on which we gather today. So in this presentation, I'll be telling the story of how our paper called the Estimating the Extent of Asymptomatic COVID-19 and its Potential for Community Transmission ended up published in this obscure Canadian journal called JAMI. And 5 years on, it's still the most downloaded and most cited paper. So I want to take you back, right back to the beginning of the pandemic, March, April 2020. So 5 years on, we've got lots of knowledge and hindsight and everything, but at that time, March and April, there was still so much unknown about this emerging new infectious disease, and there were case reports emerging from China of completely asymptomatic patients, yet still test positive, and reports of initial big infection clusters such as the Diamond Princess cruise and the famous clusters around the world, in America as well. And then there was this rapid review from Center for Evidence-Based Medicine, summarizing few studies that had reported asymptomatic case prevalence from 5 to 80%, which is quite a big range. And it was one of the important questions that were being asked. There were so many questions at the time, but not very many reliable answers were coming out. So we decided to do a proper systematic review to determine the estimate of asymptomatic case prevalence, and if there was data available, then estimate the transmission rate of asymptomatic people compared to symptomatic people as well. And this picture is one of my favorite photos from the pandemic. I mean, it's a very sad photo taken in the Greek islands. So the conduct of the systematic review, we did it over in 12 working days in April 2020. This is our team there, 6 of us there. Justin is our information specialist, and he's very good at what he does. And Paul, Mary Louise McLaws, Magnolia, and Katie were all had medical doctor background, yet they were all very, very experienced experts in infectious disease epidemiology, evidence-based practice, and so I had the privilege to work with them and learn from them from the beginning of this pandemic. So we looked at the close contacts of PCR-confirmed positive cases who were followed up at least 7 days from their contact. And initially we were looking at studies that were followed up people, close contacts, for 14 days. But at that time as well, March, April, things were moving at a very fast pace. Every day there were new kind of parameters of this condition were being renewed and or informed. So during the first week of our systematic review conduct, the incubation period became very clear that it was just over 4 days. So we thought, okay, 7-day follow-up could be enough, and that just added just a couple of more studies to our inclusion. We excluded just a single case clusters centered around just a single positive case, and then other unsuitable study designs as well. And for the risk of bias, we used combination of key questions of prevalence and diagnostic accuracy studies, particularly around case ascertainment, and to reduce the selection bias as well. And we were able to do provide 2 estimates meta-analysis. So the findings, we screened almost 2,500 titles and abstracts and assessed 161 full-text articles, many translated using Google Translate from Chinese. and in order to check if they were includable or not. So we ended up including 13 studies, 9 published and 4 preprints from 7 countries. And 5 studies were set in aged care and nursing facilities, and 8 were in the community setting. Altogether, there were over 20,000 close contacts were followed up of 850 or so confirmed cases, of which 663 were ended up positive, and of which 111 were completely asymptomatic. So this is the fixed effect pooled estimate meta-analysis showing the 2 subgroups by the aged care and non-aged care setting. And overall, the fixed effect meta-analysis estimate was about 17% of all cases were asymptomatic. And there was considerable heterogeneity as well, but 84% heterogeneity was actually the smallest heterogeneity of this. The 2 other similar systematic reviews on meta-analysis came out around that time. I think they had like 99%. 9-point heterogeneity as well. And so we were very surprised by the finding as well, because around that time, the speculation, the kind of common the rumor going around was that the asymptomatic people are driving this pandemic. There's no other way that this pandemic could spread this fast around the world unless the significant percentage of the infected people were asymptomatic. Roughly, over 50%. There were some people are saying, oh, it must be 60, 70% of the cases must be asymptomatic. Otherwise, it couldn't be spread this fast. So we've got this 17% estimate, and it was very low, we knew, but we also knew that we did conduct proper systematic review, so it was more correct, we believed, hoped. And we also had 5 of the included studies provided sufficient data to calculate the forward transmission rates, and the fixed effect overall relative risk was 0.58, which means asymptomatic people were transmitting infections 42% less than the symptomatic people. I mean, looking back, it makes sense because they weren't, sneezing and coughing around. But interestingly, the viral load tests of these asymptomatic and symptomatic people were not different at all. They were exactly the same viral load, but shedding was, we didn't have enough data to estimate the shedding of the virus. So now the publication, so we knew we did a decent study, and we were excited that it was one of the earlier studies providing answers to some important pandemic-related question. So we started high on the level of impact factor of the journals. We didn't know any editors directly, personally, so we just blindly submitted. And we got 4 rejections in 2 weeks from all the big name journals, and also with some comments as well accompanying the rejection, which was one of the very prominent medical journal editor wrote that the authors took very strict approach to what studies are included and didn't consider any other rapidly emerging studies. And that yellow emoji is Paul. He was very angry, and he said, well, that is a systematic review, don't you know? And also there were comments that saying, we don't believe that 17% is anywhere in the right ballpark, it's too low, can't be true, and things like that. And we, whilst we were getting rejected and submitting around, we updated the search twice to keep it really up to date and including the latest possible evidence available. And we didn't know what to do after 4 rejections. We put it up on medRxiv, the preprint server, and it got downloaded 20, 30,000 times in the next 3 months until we found a suitable journal. Then the rescue came on Twitter, and like Mark was also talking about, on Twitter, there were things were happening on Twitter, as you know. There were a lot of speculations. It was hard to say which one was the real expert or armchair expert, and there was lots of fear-mongering and over or underestimation of a lot of things, misinformation, disinformation, you name it. Funnily enough, at the same time as we we posted our preprint link and kind of said we found the estimate was below 20%, quite certainly. And two other systematic reviews that also did the similar estimate to ours was also well below 20%. So then it was causing a little bit, of discussions, and luckily the editor-in-chief, Gerald Evans of the JAMI Journal, happened to see our paper, and he was interested in reading the full thing. So we submitted to JAMI, and we got an actually very, very good peer review from people who knew what exactly a systematic review is, and it was really good. And so we got it published. It got accepted on 1st of September. And published online in December, I think. Had to wait a long time. And in September, at the same time, I think many of you would know Dr. Eric Topol. He's very prominent on Twitter, and he was tweeting about the pandemic and everything related to it constantly, and he happened to have conducted a narrative review with a colleague of his, which he included only 16 studies that received a lot of publications, like the US Navy ship, and then the Diamond Princess cruise, the Japanese repatriation flights from Wuhan to and things like that, which we excluded because they did not have a very clear follow-up of the same cohort of people, after 7 days. And the case ascertainments were also very unclear, and so I kind of got into not a Twitter feud, but I challenged Eric when he posted his narrative review and said, their estimate was the asymptomatic case prevalence was about 40 to 45%, and it's quite significant, and it's really, driving one of the driving factors of this pandemic spread. And so we said, well, our systematic review estimate was well below 20%, and we don't think it's, one of the things that's driving this pandemic. And so I guess I thought time will tell. And so I wanted to update the evidence to present at the conference, and I just had a very a quick update I did in April. There were 11 more new systematic reviews providing asymptomatic estimates on the asymptomatic cases since the 2020 paper. So as you can see, there are, three papers. The first three dots around 20% mark is the first three papers that came out. One of them is ours, and since then there were 11 new studies, and I'm still working on the data and how best to present it. I try to look at their search date of those systematic reviews, try to match it up with the virus variants, but I don't think that's very accurately reflecting the waves, corresponding waves. And their estimates, point prevalence is ranging from 8 to 45%. So apologies, this is not the final thing, but we'll continue working on it. And so watch the space. There's update. We'll, I think, publish it as maybe in the form of some short piece or an editorial or something, if not another updated systematic review in the coming months as well. So our take-home message is that the prevalence of truly asymptomatic cases were much lower than speculated, and the transmission risk was almost half of that of the symptomatic cases. And we said, so therefore it is unlikely the asymptomatic people were driving the pandemic. And always focus on the high quality, low risk of bias studies, no matter what anyone says. Reliable and accurate estimates of infectious disease or outbreaks is very important for the modeling studies and has implications for policy and public health measures. And when the next pandemic hits, you can use our paper as a protocol to determine the asymptomatic case prevalence and the forward transmission rates. Thank you. And I want to again thank my co-authors. Sadly, Mary-Louise McLaws, who's an infectious disease expert and a consultant to the WHO, had passed away in the second year of the pandemic. And so I honor her with my presentation. And so if you have any questions, you can email me. I work at the Institute for Evidence-Based Healthcare at Bond University in Gold Coast, Australia. Thank you, and happy to answer any questions during the Q&A session. Thank you.